Morning.
Good morning.
Hello.
Hello.
Let's
See. Just
Hey,
let
Sid.
everybody in.
How are you?
Good. How are you?
Here you are. Good. Yeah. Oh, kind of early, everybody, but welcome. We'll just wait another minute or so to just make sure we get everybody in here before we start the conversation. But how's everyone doing? Have a nice holiday weekend?
Yes.
Yes.
It's good. So are you enjoying your tasty breakfast? Feel free to to have some while we're doing this, just so it just kind of makes it a little bit more informal if we're hanging around drinking our coffee. And I mean, I'm not going to eat this until after because I have to talk, but feel free to like put some in your mouth while we're doing this, because that's kind of what the whole idea of this is. Oh, okay, got a couple more people coming
in the middle.
In the corner.
No, I know where you are.
Yeah.
Right, we've got a good sized group today. Just I guess we can. I'll just start. I'll keep admitting people if they start coming in, but I guess we can kind of get going with this. I've got a couple of announcements to make to start, just like I kind of normally do, and then we'll let Dr. Margolis take over. So good morning, everyone, and welcome to this Ask the Doctor Zoom discussion with Dr. Jeffrey Margolis. Oops, I'm admitting people. Oh no, can't do it that way. For those of you that don't know me, I'm Michelle or Mickey McWilliams, and I work with Sid Moss at Cure Multiple Myeloma Corporation. Before we begin, I'd like to ask you to keep your devices on mute unless you want to speak. That cuts down on the interference noise in the room. Dr. Margolis is president of Michigan Healthcare Professionals, PC, and professor of oncology at Oakland University William Beaumont School of Medicine. Before we begin our discussion, I'd like to thank our very important partners, Oncopeptides, Karyopharm Therapeutics, Sanofi, Bristol Myers Squibb, Adaptive Biotechnologies, Amgen, and Nova Pharmaceuticals. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. I also want to introduce Sid Moss. Wave, Sid.
Hey, everybody.
The founder of Cure Multiple Myeloma Corporation. Sid and his organization are responsible for these great breakfast treats. So, thanks, Sid.
You're welcome.
So the way this will work is Dr. Margolis will provide us with a little background on himself for those of you that don't know him. Then he'll give us an update on treatments and any other news as it relates to multiple myeloma. Then we'll open it up to questions from you. Please use the chat button to type in a question anytime during the discussion. I'll read all questions sent to me in advance and from the chat. Plus, we'll unmute and take questions from the floor. So again, thank you for taking the time for this discussion. Take it away, Dr. Margolis.
I thank you. Can I see everyone's smiling face who's on with us, or is there a way to? We see I get the Hollywood squares here, I think.
Yep. I'm admitting a few more people just as we talk right here, but.
That's terrific. So for those of you that don't know me, I'm Dr. Jeff Margolis. I'm a practicing medical oncologist, and I'm a clinician and spend my days actually treating and taking care of patients. And I'm the beneficiary of taking care of great people like all of you. And this is a really exciting time in myeloma, because this is a day that we can talk about some really new, great treatments, and a lot of things are happening in the treatment. So I guess the first thing is I'd just like to take some general questions, and then I'll jump into the kind of things that we can talk about.
So this
Any
is,
questions?
yeah, this is your time to unmute and ask a question if you have something that you want to ask Dr. Margolis right away. No one? I did get one question from an email question before, and it's about what everybody's been talking about, and I know this is something on all of your minds, but it's about the vaccinations for COVID-19 and its role with multiple myeloma patients. This one was just the question is just had the vaccinations last week anything new on on how that's all it says here really, but on how it's affecting patients with multiple myeloma. Can you talk a little bit about that?
Sure. So as you're all still aware, and the reason that we're in the situation we're in right now, talking on Zoom and not in person, is because we're still in the middle of a pandemic. Fortunately, we've got 3 really great vaccines that appear to be highly, highly effective in preventing patients from getting COVID, and more importantly, preventing people from dying and being hospitalized from COVID-19. And what we know about the vaccines is that in now millions and millions of people that have had the vaccine is extraordinarily safe. So I have no reservations about recommending the vaccine for people based on safety data from the original clinical trials, as well as from current use. So all the vaccines that are being put into people's arms are being monitored on a daily basis. We're doing almost 3 million vaccines a day, and we're not seeing terrible, terrible side effects. I personally have been vaccinated. My family has been vaccinated. My in-laws have been vaccinated. So I cannot stress enough how important and how safe the vaccine is. With that being said, we have more limited data on people with myeloma who have gotten the vaccine. I can tell you that in our office, we've vaccinated lots and lots and lots of people with myeloma. And again, I can tell you I've seen no safety issues whatsoever. The question is, how effective is the vaccine in people who have myeloma? And people who have myeloma present a special problem in that when you have myeloma cells, sometimes you suffer from immunodeficiency, so you don't make good immunoglobulins. And one of the things a vaccine is doing is trying to make your body make immunoglobulins. And those are some of the things that you use to fight off infections. And that's why people with myeloma are at increased risk for having an infection. In addition, a lot of the medicines that we're giving you actually tap down the immune system. So drugs like dexamethasone, drugs like Revlimid, Pomalyst, Melphalan, Cytoxan, Velcade, all those medicines potentially suppress the immune system and may make it harder for a vaccine to actually work. So there are no studies that have been done yet, specifically in myeloma, to look at the efficacy of the vaccine, meaning how well does it prevent disease. When we give people statistics that the vaccine prevents 95% of people from getting infected with COVID, that's absolutely true in the general population. Whether that's still true in the patients with myeloma remains to be seen. We have a small retrospective study that we're doing at MHP, looking at people with myeloma and other hematologic malignancies. And what we have seen so far is that not everybody with hematologic malignancies, including myeloma, have had antibody responses. So when we give people a vaccine, what you normally would see is an antibody response about 2 weeks after your vaccine. The antibody response should continue to go up and should peak around 2 weeks after the second vaccine. There are also T-cell responses. And unfortunately, we can't measure T-cell responses. So we know in our preliminary look at the data, and this is unpublished data, I just looked at the data a couple days ago. In myeloma patients, about 30 to 40% of people have not had antibody responses to the vaccine. And in patients who have chronic lymphocytic leukemia, less than 50% of the people had responses to the vaccine in the IgG to spike. That doesn't necessarily mean that you're not immune. It means you didn't have an antibody response, and we don't have ways yet to measure T cell responses. So what I tell everyone with myeloma is that now's not the time to take your gloves off. Now's not the time to, to get crazy and start going out. You're going to depend a lot on this herd immunity for other people to be vaccinated. So it's still very, very important for myeloma, even if you've been vaccinated, to continue to practice social distancing, continue to wear your mask, and continue to be cautious. With that being said, there is growing data that people with normal immune systems who've been vaccinated, not only can those people not get sick, it also appears that they're not going to be able to spread the disease. So I think very soon you're going to start to see the number of COVID cases starting to go down. The ability to interact with people will change, especially interacting with people who have been vaccinated, because not only are the people who are vaccinated protecting themselves, they're protecting other people. Any questions about that?
Yep, go ahead.
Yeah. Dr. Margolis, thank you for sharing. The question I have is kind of related to a study that I'm in. By the way, I was originally diagnosed by your dad. So I thank you guys. I'm going to have a bone marrow biopsy today. Am I going to see anything special given the fact that I was immunized in January, and then the second one was February the 7th? As I look at, and will I learn anything about whether or not I'm in that 30%, 40% from a bone marrow biopsy?
No. So the bone marrow biopsy is looking for myeloma cells, and it's being done specifically for that. Theoretically, you could try to look for activated T cells against COVID, but right now that's not commercially being done, and there's only a few studies that are being done on it. And actually, most of that's actually being done on, peripheral blood. So you've got the right medium. There's a lot of things that you could do with it, but there's no answers yet, on vaccines. The only thing that we see, on vaccines as far as disease is if you get a vaccine and then you do a PET scan within 4 to 6 weeks of the vaccine, there are some people who are getting swollen lymph nodes underneath the arm that they've been vaccinated, and some of those will become PET positive. And so if all of a sudden you got a PET scan as follow-up for your myeloma and someone said, oh, you've got some activity under your arm, it's not the myeloma that's doing it, it's definitely the vaccine.
Thank you.
You're welcome.
I have a question.
Yeah.
I just had my second vaccine on Sunday. Now, is it something that we should go have tested for those antibodies after 2 weeks, or should we just let it go, or what should we do?
Yeah, great question. So when you look at the vaccine, the general recommendation for the population is that you don't do any antibody testing, because no one knows exactly what the antibody testing means. It's kind of a double-edged sword when you do it. If you do it, you have to make sure you get the right antibody testing done. There's 2 types of antibody tests that can be done. One's to the capsule, and that's what most labs are doing. And if you've been vaccinated, the capsule's the jacket that the virus wears, and that's what most people are testing to see if you've been infected. The antibodies that you make to this are to the spike, which is the little horn on the end of the virus. So if you have had disease, your capsule will be positive and your spike will be positive. But if you've been vaccinated, that antibody will be negative. And it's not because you didn't respond, it's because the vaccine doesn't make antibodies to the spike. If you go further and you get the correct test, which is the antibody to spike, you can have it. It's a nice feeling when it comes back positive. You say, hey, yay, I responded to the vaccine just like everybody else. There's a chance that you are going to not have a positive antibody. And if that antibody is not positive, it doesn't mean that you're not immune. It doesn't mean that you haven't responded. We just don't know. It makes us all feel better that you have an antibody. We don't know what antibody level corresponds to, hey, is your antibody level high enough? Does that mean you're protected? So I think you just have to be cautious when you have a disease that affects your immune system, that you can't 100% get the antibody and then say, hey, everything's perfect, I'm going back to normal. Where if you had an intact immune system, you didn't have myeloma, I'm much more liberal with what I tell people.
Okay, should you do that with like your oncologist or
Yeah.
your, okay,
It definitely needs to be done with your oncologist. You need to have a talk beforehand, before you do the antibody, because again, we all deal with myeloma and bad things that we have to talk about. And I can tell you, one of the least pleasant conversations I have to have with people is you do a COVID antibody and it comes back negative. I think everybody is waiting for that antibody to come back positive so they can say, hey, my life's back to normal. And that's a very difficult conversation to have. So it's very important that you have that conversation before you do the test, because it's definitely not for everyone. And you have to take in mind that the test may not be predictive. We're working on trying to find some T-cell tests to look at another way to do this. And I think coming soon, we're going to be doing tests to figure out who's immune and who's not, try to figure out how long does this vaccine last, who's going to need a booster, are there other strategies? Because we came up with some ideas right at the beginning, which is if you get a Pfizer or Moderna, you need 2 shots. If you need a Johnson & Johnson, you need 1. It may mean that if your immune system's weaker, you need 3 shots of the Pfizer, or maybe you need 2 shots of the Johnson & Johnson. Maybe the dosing is different. So all this stuff still needs to be worked out, and it's an area of very active research.
okay, thank you.
You're welcome.
Dr. Margolis, I have a secondary question.
Sure.
You mentioned studies in the future. How do we get informed about studies? And if you're in one study, how can you get in another study?
So there's two types of studies. There are disease-directed studies, and those are studies that are taking treatment that are active against the myeloma. Then there are studies that I call supportive care studies that are doing things to try to ameliorate symptoms. And then the third study are the COVID studies. And so some studies will have exclusions for you participating in other studies, but many studies will allow you to be in a disease-specific study and then also participate in a COVID study. You just can't do 2 disease, specific trials. So you can't do, one treatment for myeloma and then layer on another study for another treatment for myeloma. But you certainly could be on a study for myeloma and then be on a study trying to get information, regarding the COVID vaccine.
Thank you.
So, Dr. Margolis, should these, in order to get on these studies, do these patients talk to their oncologist about that? Is that normally the way that that they would get into a study?
Study for myeloma or study for vaccine?
I guess either.
Yeah. So your oncologist has access to all the myeloma studies, and we've always had access to the myeloma studies and can get you on those. MMR is a good place to look for, and we've got plenty of resources for that. The COVID studies have mostly been run through the infectious disease group. I happen to be very active, and we have a myeloma, a COVID link through MHP, and we're actively doing studies in COVID patients. And so those studies are available through me at MHP. I'm sure at the other major centers that are also doing studies in COVID, it may not be through their oncology department. It may be through their infectious disease department, but things are being talked about. In addition, a lot of these COVID studies, you'll hear about these things, in the national press or on television. And if you start to hear about them, go ahead and inquire, because these studies are not studies that are typically being done at a single institution, but they're being done throughout the whole country. So for example, one of the things that we have open in our office is that for people who are infected with COVID, we have a monoclonal antibody. So it's a pre-made protein against the COVID spike, very similar to the cocktail that President Trump had gotten. Eli Lilly has a cocktail of drugs that have been done. And when that cocktail is given very early in the treatment of myeloma, in the treatment of COVID, 88% of the patients who received the monoclonal antibody never required hospitalization, and about 60-70% of those patients within 24 to 48 hours, all their symptoms go away. So there's some very effective treatments if you get it early. The key for the trial that we have that's open using the drug is you have to get it early. So we need to see patients within 3 days of testing positive for COVID. We need to get them on the trial.
Dr. Margolis, this is Hal Anderson. I had COVID infection back in November, and I was, the latest information I was able to determine was that I might be immune to reinfection for up to 5 to 7 months. And then in March, I got both of the Moderna vaccines, so that I'm expecting another. Do we know how long I can expect to get immunity from the shots? I mean, I'm believing right now that I'm going to need to get a booster every year, just like the flu shot. Is that what you understand?
Yeah, we don't know yet. So it's too early. We know that the studies that have looked at people who've been vaccinated, they've got people that are out more than 6 months. And at 6 months, the vaccine still looks like it's protective in the general population. We don't know about myeloma. Part of the reason that you get a flu shot every year isn't because you lose your immunity. It's because the flu virus mutates and it changes. So each flu vaccine that you get each year is slightly different from the flu vaccine you got the year before. One of the reasons that everyone's talking about these variants is that we're hoping that's not what's going to happen with COVID, is that we're going to continue to have variants and we have to keep tweaking the vaccine to keep up with it. The best way to make sure that doesn't happen is to wipe COVID off the earth. And just like smallpox, theoretically, smallpox could mutate and you could get variants. Well, you can't get variants of smallpox if there's no smallpox. And so one of the keys is going to be to vaccinate everyone in the United States, but to vaccinate everyone else in the whole world. Because if you get all the variants covered here in the United States, and then COVID's going like crazy in Brazil, they may get mutations and get variants that eventually will come here that our vaccines may not be good for. So you're in the same boat right now as everybody else. You got at least 6 months, and we're in the process of still sorting all this out.
Right. I have a question. Oh, go ahead. If someone has a question, go ahead.
Yeah, it's for doctor. I have smoldering myeloma. How does all this affect my situation?
So from the issue of smoldering myeloma, it's the same. That people who have myeloma may not respond as well to the vaccine as the general population. It's because of underlying disease and also because of the drugs that people who are have myeloma are being treated with. The fact that you have smoldering myeloma and you're unlikely to be on any treatments may mean it's more likely for you to respond to a vaccine. We just don't have that information because the studies were done with all comers and they didn't do a subset of studies and said, let's do vaccines just in people with myeloma. Other questions?
I have one from the chat here. It says, how often do multiple myeloma patients present with chronic ITP as well? How would you treat that patient type?
Yeah, ITP is another immune disorder that can occur in patients with myeloma. And it's not an uncommon thing that happens with myeloma. And there's a variety of treatments that you have for ITP. And it really depends on what medications the patient's on, what their situation is. And it's very difficult at a chat like this to give a specific.
Here's another one from the chat. Do you know if Detroit Carmanos can test the spike for the COVID antibody after getting the vaccine? If not, can we schedule this test at your office?
Yeah. So the Carmanos itself is not a lab. And so Carmanos sends their blood to a lab. Most of the lab that they use is part of the Detroit Medical Center. I don't know which antibody they're doing there, but if they don't do it there, they can certainly send it out. The lab that we use, and MHP's lab, is called Biotech Lab, and that's the lab that's affiliated with MHP. We do the spike there. 2 national labs definitely do the spike. LabCorp actually has a contract to do COVID antibody spike with Moderna, and you can get the lab done there, as well as Quest. So there are a variety of labs, and then you have to go from hospital to hospital to figure out which platform that they're doing. But any cancer center, even if it's not done within their center, can send that blood out to a center that does the antibody test. You just want to make sure it's an antibody to spike.
Antibody to spike.
Dr. Margolis, I hate to ask all these questions, but does Prolia have any issue with the vaccine, given the fact that many patients will see osteoporosis as one of their symptoms?
Yeah. So when as we talk about myeloma, we talk about drugs that are affecting the disease itself. And those are the Revimids, the Velcades, the Darzalex. And then we have supportive care medicine that are affecting complications and symptoms from the disease. And one of the things that happens in myeloma is that those plasma cells attack the bone and weaken the bone. In addition, all the steroids that people are on can increase your risk of osteoporosis. So drugs like zoldronic acid and Prolia are actually aimed at, and Xgeva are aimed at rebuilding the bone. And so those are the same medications that are actually used in benign conditions like osteoporosis. And those drugs don't have, and again, in that supportive care group, so they would be unaffected by the vaccine. Other questions?
Anyone have another question? I'm sure you do.
I'm sorry, I came on late. What is it called? COVID antibodies 2 spike test?
It's a COVID antibody to spike. So it has to be to the spike protein, not to the core or the capsule.
And our oncologists should know what that is.
Maybe, maybe not. So again, there's a lot of crosstalk between specialties, but COVID's not what all oncologists do. So they may not know that there's subtle differences between the two. But if they don't, they certainly have support within their institution of infectious disease doctors and people that can help them. I'm available if they want to know about that. It happens to be an area of clinical interest that we have and something that we're actively studying.
Okay, thank you very much.
Other questions? All right, well, one of the things I thought I would share with you is today's actually a very, very exciting day to me in myeloma and talking to all of you, because I think that during our panel discussions, we've had multiple discussions on the use of CAR T-cell. And every time we tell you and we ask the panel, what's the most exciting thing that's happening in myeloma? All of us always kind of agree that CAR T-cell is the thing to do. And then we finish off and say that it's an experimental treatment. It's available at University of Michigan. It's available at Carmanos, but it's a study. There's a big wait list to get onto the study. Well, today I'm here to tell you that CAR T-cell is actually here for myeloma. It has arrived. Ide-cel is Bristol Myers and Celgene's CAR T-cell. It is an FDA approved treatment. So congratulations to everyone on this call. There is now another amazing treatment for myeloma that wasn't there before. And this, is really a groundbreaking treatment and treatment class. It's the beginning of a whole new world for people with myeloma. So we're really excited that this treatment is now available. And based on some very early data from the KARMA trial, the FDA has granted it accelerated approval.
Who qualifies for that?
They're for people who have very refractory myeloma. You've had to fail at least 3 therapies. And then it's going to be individualized, with you and your physician. All the myeloma doctors you're seeing are all aware of this treatment. Typically, CAR T-cell therapy is approached through the stem cell arms of most treatment places because it still has significant risk and significant toxicity. And so it would be very similar to being evaluated as screened for a stem cell. You'd go down and you'd talk to your myeloma doctor. Your myeloma doctor would discuss with you if CAR T-cell is something that you'd want to consider. If CAR T-cell is something that you'd want to consider, they would probably send you over to the stem cell transplant doctors or the people that are administering the CAR T-cell, and then they would talk to you about CAR T-cell and whether you qualify.
Thank you.
Oh,
Doctor, do you expect that Medicare will cover that procedure?
They will cover the procedure. There have been issues in the past with CAR T-cell and how the coverage has worked with CAR T-cell. CAR T-cell, like all therapies, is a drug, and there's nuances with the way that hospitals get paid. And hospitals get paid as a bundle into a DRG. And so when you're admitted to the hospital, they don't itemize out the individual pieces that you get. They charge you for the hospitalization. The problem with CAR T-cell is that the CAR T-cell drug itself is typically they're between $400,000 and $600,000 for one dose of the drug. So when the hospitals were admitting people at the beginning to give CAR T-cell, the patients were being admitted for CAR T-cell therapy. Medicare was reimbursing for the admission, let's say $100,000, and the hospital was buying the drug for $500,000, and they were losing $400,000 every time they did a CAR T-cell. So Medicare said, well, hey, we're paying for it, but the way they were paying for it wasn't correct. So in order to try to get around this, most CAR T-cell therapy now is trying to be given as an outpatient so they can build a CAR T-cell, and then when you get admitted to the hospital, the hospitalization would be separate. The issue is that if you get the drug and then you get admitted within 24 or 48 hours after getting the drug, it actually gets bundled into it and causes a problem. So the manufacturers, the people who are doing CAR T-cell and all the centers are working very, very closely with Medicare and the insurance companies to try to resolve the payment issue with CAR T. It hasn't curtailed, us doing it, and we're moving forward with doing it, but there's definitely still some insurance glitches that need to be worked out.
I wanted to just say that I got a message in the message chat. It said that there's some of you that may have missed part of this. We are recording this, and I do put these recordings up on our website afterwards. So tomorrow or the day after, depending on how long it takes us to get it up, we will have this recorded and up on our website so you can review it along with the other discussions that we've had.
Can you give the website address again?
Yep, it's curemultiplemyeloma.org, and it'll be under the button that says events. It's under the Ask the Doctor discussions. It's on that page. And I will send out an email to everyone once it's up there with a link to it so that you can go in and see this whole thing all over again if you want, or skip through parts of it, or whatever you want to do. It'll be there for you to review. Okay, and I do have another question here from the chat. If you see your antibody test results on your portal, can you tell which of the 2 tests was used?
You can, but it takes a lot of understanding what was done. And it depends on which lab and how they're reporting it. If you've had a vaccine and you've never had COVID, the only way the test could be positive is if it was to spike. If you've had COVID, then I can't tell whether it's from being vaccinated or from the disease itself. Some of the portals on the websites will say which platform it's from. Some of the portals, depending on what's there, there'll be an explanation under the test of what was, or what was being done, or it'll tell you what platform is being done. So it's best to really ask the lab what the antibody's done for. It's even sometimes hard for me to tell when I just look at the patient printout piece of it, because sometimes you can't see it all. Other questions?
No more questions?
Dr. Margolis, Nancy Haida. I had both immunizations. However, the first one I didn't have any side effects, and the second one I just barely had a sore arm, and I wondered if I should be concerned about that.
So, the majority of people who've had the vaccine are just like you. So the fact that you didn't have side effects doesn't mean that the vaccine didn't work. Remember that almost 50% of people who get the COVID virus itself don't have any symptoms. So it's not a surprise that a lot of people aren't going to have a reaction to the vaccine. So consider yourself lucky that you didn't have a reaction.
Thank you.
You're welcome.
Mm-hmm.
Other questions?
Yeah, Dr. Jurioth, if you go for a month or 2 without the blood test being able to read any M protein, how long would you have your patients go under that condition before considering an MRD test?
So MRD test is similar to doing COVID, vaccines. In that you can do the MRD test, we just don't know what it means. So when you do testing for minimal residual disease, the assumption was that if you had minimal residual disease, that you would be someone that's going to live longer, or you need to have, less treatment or more treatment. We just don't know what to do with the answer. I think that all of us always think that less myeloma is always better than more myeloma. But if you have minimal residual disease, you don't have an M spike, you're feeling good, you're doing good, I certainly wouldn't change my treatment and chase after, MRD status. I think that MRD status is an interesting surrogate to look at in the research setting. So if I was comparing treatment A and treatment B, and one treatment had a higher MRD status, we would like to think maybe that treatment's a better treatment, and that over the long run, that treatment may be the one that's going to show more promise and make people live longer. And sometimes you don't want to wait years and years to find out how well one treatment does, so you can use that kind of as a surrogate. But right now, it's not something, that we routinely do. If you do it, it's the same as that COVID antibody. Be prepared that it may not come back the way you want. And as long as you understand that if you do it and you were really happy because you had no M protein, and then you do an MRD test and you got minimal residual disease that's positive, I certainly wouldn't lose any sleep over it. I'd still say you have no M protein, be happy.
Go ahead.
Any
Is there
other?
another question?
Just wanted to clarify something you said earlier, that the important test for myeloma patients is the antibody to spike.
Well, the people who have had vaccinations, to look for vaccination responses, if you're going to look for a response to a vaccine and you're doing an antibody, it has to be to spike. The vaccination is to produce an antibody to spike. It does not produce an antibody to capsule. So because of that, if you're doing an antibody that's testing for capsule, it will be negative even if you have antibody, because you're not making any antibody to capsule because you weren't vaccinated for capsule. You're only vaccinated for spike. We don't know if you're a myeloma patient and your antibody test to spike is negative. That doesn't necessarily mean that you're not immune. It just means you didn't make that antibody. And it may mean that your immunity is more dependent on the T cell immunity that you have rather than on the B cell immunity that you have. And we know that the vaccine induces both T cell and B cell immunity. It's much easier to test for B cell immunity than it is for T cell immunity. And there are certainly some labs that are doing on study looking at T cell immunity. It's just not easy to commercially do T cell antibody, T cell testing in patients to order the test.
Thank you.
Other questions?
Dr. Margolis, now with T cell in the toolbox, which is just phenomenal. How far along are we, would you say, on the path to, I'll say, a long life cure for those that are diagnosed in the earlier stages?
Yeah, I think we're getting there. And I think when you start to look at things now, we've got so many tools in the box. Now it's really a question on which combination and how you use things and when do you sequence things. If you look at CAR T cell as an example, the people who are on these CAR T cell studies, these were the worst of the worst myeloma patients. These were people who failed all the drugs that you know. There were multiple studies. They had stem cell transplants. And despite all that, some of these patients actually went into remission. Some of them had minimal residual disease that was absent. You didn't find anything, and some of them had CRs. With all that, being said, it didn't work for everyone, but they used it at the very end. So the question is, when stem cell transplant first came out, the idea of stem cell transplant was a treatment of last resort. Well, we now know if you move stem cell transplant up in the treatment, that it improves survival. So the question now starts to become, okay, now that you have got CAR T, maybe you don't wait for CAR T to be used at the very end. You start to use it at the very beginning. Is it better to do a CAR T study treatment and then use treatment after CAR T cell like we do after transplant, use maintenance treatment? Is it better to do CAR T instead of a transplant? Or do you do a transplant and then when you have very little disease left, clean everything up with CAR T after? So those are all the kinds of studies that are going to be popping up over this. And every time that you add a tool to your toolbox, you take all the old treatments that you know and then add it to different combinations. And over the last 3 or 4 months for myeloma, we've added another 2 or 3 drugs to the toolbox. So because of that, we've got lots and lots of different combinations and a lot of different things that we can start to try. One of the keys is to have these clinical trials available so we can try to figure out which of these combinations is actually the best combination.
Thank you. That's outstanding.
So, Dr. Margolis, can you explain this CAR T cell therapy, what a patient goes through and, how does it affect your life? Is it like a bone marrow transplant where you have to be quarantined for a while, or is there? Can you kind of
Sure.
give us a little bit of background?
Yeah. So the first thing that happens with CAR T cell therapy is similar to the transplant. You go through a pheresis process where they take some of your blood and they take some of your T cells out. Very, very similar to how you would collect stem cells. The big difference is that those pheresed T cells are then sent to a company. And in this case, it's sent to Bristol Myers Celgene. And they actually take those cells and they genetically engineer those cells to kill a protein that's on normal B cells as well as on plasma cells called BCMA. So these T cells are basically engineered to kill myeloma cells. So they're not natural T cells. They're basically made to be Superman cells that go in that are, you know, the SEAL team against myeloma. So then what you do is you go to the hospital, and usually a week before, they give you some chemotherapy. And they give you chemotherapy not to kill the myeloma, but to actually weaken your natural immune system. And the reason for that is they don't want your natural immune system to kill off the SEAL team when it comes and hits. So you get this chemotherapy, and that's done as an outpatient. And then your immune system is suppressed. And then we infuse in these genetically engineered T cells, just like you do in IV. Very similar again to the stem cell process. Cells are unthawed, you get the cells come in, not much happens. Well, as those SEAL team starts to hit the beach and starts to kill off the myeloma cells, you start to get something called cytokine release. And cytokine release is inflammation from these T cells activating and working. And as the T cells start to kill off the myeloma, these cytokines start to go up, and these cytokines is what makes you sick. And you can be getting CAR T cell, everything looks beautiful, nothing going on. And then a moment later, you can get very sick. You can get fever, you can get chills. You can actually start to get inflammation in your lungs. Your oxygen saturation can drop. The most concerning side effect that people get is there's a neurologic side effect, and that people can be walking, talking, and the next thing you can get very confused. You can have a seizure and then get very sick. So the way that the CAR T cells are done is we infuse them. We keep a very close eye on you. You have to be very close to the hospital. We typically carry a special bed that's available to you. There's an ICU bed reserved just in case you need it. If the cytokine release is very mild, we don't do anything except give you some Tylenol. If the cytokine release starts getting more severe, we actually use medications to tap down that immune response. We know that part of the cytokine release is from a cytokine called IL-6, and there's actually a special drug that turns off IL-6. The hospital's got special vials of this drug already with your name on it, just in case you need it. And if you start to get some of these, symptoms, then they start to give these drugs to tap down the immune system. What we know is that early on, when CAR T cell was first being used, there were a lot of very bad toxicities, and it was much harder to manage. As we've gotten better at doing this, the number of people who've gotten really ill has gotten smaller and smaller. We've been able to jump in and intervene earlier. And just like stem cell transplant, when stem cell transplant first started, 20% of people got stem cell transplants, didn't make it out of the hospital. Now it's less than 1%. We're seeing the same thing with CAR T cell, and that the ability to manage the side effects is getting better and better and better. But that's why CAR T cell will not be done at every hospital. It will not be done, in an individual office, and it really needs to be done by a true expert who's got experience doing CAR T cell with a CAR T cell team. So a CAR T cell team, is usually a stem cell transplant doctor, a coordinator, the nurses that are trained in using CAR T. There's an ICU staff that's trained in doing CAR T. So it's all there in case you get into trouble to get you out of trouble. After the CAR T, after the initial 9 to 10 days, most people look pretty, normal. They function pretty normal. We know after CAR T cell that many patients don't make immunoglobulin for a while. So some people will require IVIG supplementation. Sometimes people's blood counts can remain low for a long period, of time after the CAR T. I've seen people occasionally will come in with late fevers and things because the CAR Ts, reactivate. Unlike a regular drug, once you get that CAR T, those Navy SEALs are in your body forever. And you can look 6-7 months down the road and you can pull out in someone's blood and you can see those T cells are actually in there surveilling, trying to kill, myeloma. Unlike a regular medication, those CAR T cells reproduce. So as they find myeloma cells, they actually replicate and they make more of themselves to kind of continue to stay in the battle. So it's a very, very unique drug, and it's a living, breathing drug. And that's why we find it so exciting. The other thing that's so exciting about it is right now, the CAR Ts are engineered to go after BCMA. Well, there's no reason that you can't target it against other things. So people are looking at now additional modifications of CAR T with other targets besides BCMA. And it may be what you need is, a combination of CAR T cells with two or three different kind of CAR T cells to finally cure this. But I really believe this is on the track to cure this. This is, Nobel Prize revolutionary technology that is really, really amazing.
Here, I've got a couple questions from the chat. Is CAR T cell treatment available for those who also have amyloidosis?
I think the question, again, it's how the inserts are written. There really are two ways that people get amyloidosis. You can have multiple myeloma with secondary amyloidosis, or you can have primary amyloidosis. The CAR T cells are not approved right now for primary amyloidosis. I'm sure there are studies available for people with primary amyloidosis that would be looking at CAR T. I don't think that having secondary amyloidosis would be a contraindication to CAR T, but some of it may be based on organ function. But that's why, doing CAR T is just like stem cell transplant. It's going to be talk to your doctor. They're going to go through some basic eligibility criteria, and then it's going to be going to the transplant, group. They're going to say, is this medically necessary? And unfortunately, there's a last step, which is, can we make sure the insurance will pay for it? And that's going to be done, with your doctor, with the stem cell team.
I have a couple more questions here. How often is there a false positive on the M protein test?
A false positive. So the M protein is looking for a monoclonal spike, and that's a specific kind of protein that your myeloma is making. When we look at that myeloma protein, we're testing it a variety of different ways. One is that we're looking for what we call a spike because it looks like like an EKG or a tracing, and when you have a lot of that protein, it just spikes up. That's just a measurement of the amount of protein in the blood. We also do something called immunofixation, which tells us what kind of protein that spike is. And then we do something called quantitative immunoglobulins. And quantitative immunoglobulins is measuring how much IgG, IgA, or IgM that you have. It would be very rare to have a spike that's not real, but the measurement from day to day or week to week can vary. So I don't get too upset if I'm following my IgG level and it was 1,330. And then 3 weeks later, it's 1,400. That may be variation and maybe within the lab. And that doesn't mean that things are necessarily getting worse. So typically in that situation, I would just repeat the lab and see what the trend is. If every time I repeat the lab, the spike is getting worse, the total amount of protein is getting, worse, then I know that that's something that's real. If it's maybe the spike is the same, but the quantitative immunoglobulins are going up, then I'm less likely to believe that that's actually true progression, and it's more likely just variation in the lab. It'd be very similar to if you took your heart rate. I guarantee that during the day, your heart rate's not always the same. It changes. There's variation. If you check your blood count, your hemoglobin is going to vary from test to test. It's not always going to be a perfect 14. It might be a 13.3. It might be a 15. It might be a 12.9. It only matters if that trend is continuing to go in one direction.
Here's another question. I'm scheduled for my second vaccine this Friday. I also take DEX or DEX on Friday and have heard I might not want to take it the same day I receive the vaccine. Would you recommend not take it on the same day?
So everybody's situation, is different. I would tell you that to make an individual patient decision, please talk to your doctor. But if you know when you're getting your vaccine and you can avoid, and it's not a contraindication to, holding your steroids, potentially holding your steroids for a week or two, before or after the vaccine has the potential to increase your chances of responding. The hardest part, I think, for this whole thing was that no one knew when they were getting their vaccine. You just kind of luckily fell into it. But in the ideal world, if you could, modify your medications during the vaccine, maybe there'll be some benefit of doing that. But don't go home and say that I told you to do it. Please talk to your doctor and ask them what they think about it. Other questions?
Yeah, we only have a little more time today for this. So if you've got some questions, please speak up now or put them in the chat and I'll ask them. Either way.
There was a new drug that came out last week that was approved. I mean, just it's a brand new one. That man that said his last name was Allen. I think that was the guy from Chicago. That used to do the fundraising. He walked every year.
Not a question, but a comment.
Sure.
Michelle, the blueberry dessert is absolutely phenomenal.
Is it? Okay, good. I'm sitting here staring at mine right now thinking pretty soon I'm going to eat it, but not yet.
Thank you, Sid.
Yeah.
Thank you very much.
We've had a lot of questions about, protein, antibodies, and then in patients with myeloma, you're constantly having, your antibodies and your proteins and everything talked about. And we're talking about a spike in myeloma, which is not the same as the spike on the COVID antibody. I'm wondering if at some point, maybe I could work with Michelle about getting everyone a little worksheet just so you can see it on paper. I think this will be much easier to illustrate and helpful for everyone to see on paper what your labs are. And I wonder, in general for myeloma, when you're getting your results, does everyone understand when the doctor says what your protein spike is, what your IgG is, what your free light chain is, what your immunofixation is? Does everyone understand what all those pieces are? And would it be helpful if we came up with a worksheet so when you got your labs back, you kind of understood what each of those pieces are measuring? Because, we seem to do these, on every month or every 3 months, and I'm not sure everyone understands all the pieces that are coming back.
That would be wonderful.
Yes. Thank you.
All right, so Michelle, why don't we work on together?
That'd be great.
We'll put together a little worksheet or something that shows what all these pieces are. And then once we find something we like, if we could get this distributed, to everyone that's on the call, I think that'd be very, very helpful. And it's very easy. I'll get it in a way that's easy to understand, but I think you need it in front of you on a piece of paper so you can see what we're kind of talking about, and it will be pretty easy to understand.
That would be.
And maybe what we'll do is I'll take a fake patient, put the results on all the things, and then go over what each of those pieces are.
Wonderful.
Yep. If you can put all that together in a way that that's understandable for people, I'll make sure that I can get that out to everyone. I could make it look pretty, but you're the one that has all that information.
All right.
That would be wonderful.
I'll see if someone already has a worksheet. If not, you and I will make one. I'll get the information. If you make it look pretty, we'll get it out to everybody.
Perfect.
Wonderful. Well, we are right at the end of our hour. So, if there's any more, just yell right now if you have a question. But if
Do
not,
you know,
Go ahead.
Nikki, do you know, does the doctor know, I'm just reading that if people have children or siblings, they're more at risk for myeloma if they already have it. I mean, should we be telling our children to be checked or look at that or ask their doctor?
Right now, we don't think of myeloma as a hereditary disease. There are some families that have clusterings of, myeloma in the family. Those families might have something to be evaluated. So if you had a strong family history of multiple members that have myeloma in the family, that's something we would certainly be interested in. It's a very active area of research. But just like diseases that we know that there is a genetic link, most of those cancers still don't have a genetic link. So if you look at breast cancer, which there's absolutely a gene that can help, that increases your risk of getting breast cancer, only a small percentage of people with breast cancer carry that gene. So if there is a gene that increases your risk for myeloma, it's only responsible for a small number of people with myeloma. But if you are one of those patients that have got a strong family history, please let your oncologist know. You're wanted in a variety of studies in the country to try to sort out this gene. And those would be the type of studies that we could actually call someone in another part of the country that's collecting that data and probably get you in that study just by sending your blood out there.
Thank you.
Well, all right, everyone. I think that now it is the end of our hour. And I think that this has been very, very interesting. I hope you all enjoyed it. And thank you very much, Dr. Margolis, for taking the time to do this. It's very, very useful to everyone, I believe, especially now during this pandemic, to have some answers or at least know where we're at with this pandemic as it's related to multiple myeloma. So we appreciate everything that you're doing. And now I'm going to be able to eat my breakfast. So,
Thank you, doctor.
Yeah.
Thank you, doctor.
Thank you.
Everyone be safe.
Thank you.
Doctor,
Take care. Bye-bye.
related to Michael Margolis with Rochester Medical Group.
Yeah, that's my brother.
Oh, that's my primary care physician.
Ah,
Oh, there you go.
Jeff.
terrific.
All right.
Small world.
Yeah.
All right. Take
All right,
care.
everyone. Take care. Have a nice
Bye-bye.
day.
You too. Bye-bye.
Bye.
Thank you. Bye.